person who will never tell ki you have to study very much in ENT, very much. No, that's not the case. But just a minute, guys. Know in total, like each and everything about the case. Hai na? So squamous is one thing, and the other being the facial nerve. These two things are such in which you cannot have an iota of a doubt that I don't know this or I don't know that. Okay, and we will be discussing this like in last session we had discussed this squamous in one go, but I felt that there were certain lacunae which required to be fulfilled. So I have broken up this presentation into two parts. In the first part, that is today, we'll be discussing the approach, like how will we approach the case per se. That's my point. And in the second class, we'll be discussing two things. Like supposedly this squamous part is there. Guys, कुछ भी issues होता है, if you have any issues in the audio or video, please let me know. Today I am not in my routine workplace, so there might be some issues of the net or weather disturbances. Okay, please let me know in case of any problem. Okay? See, in this type of scenario, one is your traditional setting which we go like, one is your traditional taking, that is your history examination followed by the viva. But most commonly, you all know that there will be so many attendees of so you might be thinking that today is the best day, like I have to give all my knowledge today. But believe me, that actually isn't the truth. That examiner who has come to take your exam, he has a flight in the evening and he just wants to finish off things in time and go back. Okay, most of the time it's the same scenario. You are not the only one. There are around 8 to 10 people at your center minimum. There might be even more also. So generally what I have seen during the last few times, that the examiner will ask you, Dr. Sir, summarize your case. What are your findings and how will you manage the case? How will you manage the case? Okay, so see, this also we will discuss that how the history going takes place. I'll present a ideal case taking. Okay, I've shared some PDFs with you. Just go through those PDFs, and apart from those PDFs, there are around 20 pages in which around 100 questions are there. Okay, these questions are the viva questions that we had during in the AFMC, Armed Forces Medical College, and basically it contains everything. Okay, the routine things which you require for passing your exam, the basic knowledge. Okay, but believe me, squamous is not a thing which you can go through in one day. This holds true for the person who are in first year. This holds true those who are waiting for your theory results, and this holds true even for the people who have given their practical and giving it for the second or third time. Okay, it's like a mixture sort of thing. Squamous, you'll be going through the anatomy, physiology, history taking, examination, management of the case, surgeries, all those type of things, and then basically that and then you are like getting that full feel of that squamous case. Okay, so that's why I've divided this class into two parts. Today we will be discussing what is the approach to how will we manage the case and how will we approach. In the second class, which will decide consensusly how to go about it, we will discuss the ideal case taking. What are the questions to be asked in history? What are the points to be looked forward in the examination? Okay, what point and how I have planned it. Like suppose in history, you will ask certain things. Sir, the discharge of the year is scanty. So along with scanty, all the questions which will be following it will be discussed there only. Okay, and apart from this, the second part which will be added over here is complications. Guys, from where have you read the complications in COM? Can I have anybody unmute your mic? आप लोग कहाँ से पढ़ रहे हो इसको? down the surroundings and Chambord. Chambord, ठीक है. So that is हाँ Chaitra, please let me know what you are following.
Chambord and the Scotland.
Chambord and Scotland, great. है ना? So I'll request now कि make your order of preference of studying first should be Chambord. Okay, and then followed by that, whatever you want to add on onto that, you add on to that. For otology, basically for mostly your temporal bone, otosclerosis, and this complications, Chambord is the gold measuring. Okay, so first go through that concept बैठाना दिमाग में, and then proceed to the I'm sorry for this noise of the train. Okay, ठीक है, got my point. So you have worked up your case. After working up, see, we'll be discussing this, okay, history and examination. So don't take this thing into your mind that history में क्या करेंगे, examination में क्या करेंगे, वो भी अपन करेंगे. We'll also do those things also. Today we'll be discussing how to approach the case. Okay, so this will be more or less an overview of the thing, what extra to be read, and from where to be read. Okay, so examiner will यहाँ पे आने के लिए ना, see, यहाँ पे आने के लिए two things you have to see. I keep on telling the people that knowledge is one thing, but presenting that knowledge is another thing. Okay, so you have to basically upgrade your viva giving skills. People who have already given their practical once will agree with me that it is not that you don't know the things. You definitely know the thing, but वो चीज आपको examiner को बतानी है कि भैया I know this thing. ठीक है, because examiner mostly the people who are old age people, these people are constipated guys. They generally don't have that very much of helping hand कि हाँ ठीक है, you are getting 9 marks, let me give it 10 and pass this student. They will give you 9 only. You have to keep this thing in your mind. So you have to tell the examiner कि भैया I know this answer, ask me. So how will you go for that thing? So these are the things that we will slowly learn. See, you have to read initially. And after reading, when you know the topic, then you can lead your examiner. Why will you lead? How example of this thing? See, you have to tell the examiner that you know. So suppose you are giving your history taking, you are going to history taking. Sir, the patient also gives history of hearing loss in the left ear, and this hearing loss is non-fluctuant in nature. And after you say non-fluctuant, just give a pause of 2 seconds and look at the examiner. So normally whenever you say something new, examiner will ask you, why did you ask it? What do you mean by non-fluctuant hearing loss? Where do you have where do you have fluctuant hearing loss? So you should be ready with your bat. I am getting the full toss, I'll hit a 6 on this ball. So as soon as he says, where will you see this fluctuant hearing loss? But you will say, sir, we see in venous disease, we see in this place, we see in the fistula. Okay, so these are the things. You should be ready with your weapons and wait that examiner gives you that option. Tell me this thing. So there only you have to go about it. So come on, like you have to imagine yourself sitting on the table, viva table, and the examiner is saying, Doctor Sir, how will you manage the case? So how will you approach the patient? ऐसा नहीं है कि you will decide it on that day itself. So you have to say, अच्छा, one mistake which people do is, as soon as the examiner says, how will you manage the case, 50% of the people will say, sir, I will do surgery for the patient. How many of you agree with me? Anybody agrees with me? Yes, है ना? कि as soon as the examiner says कि Doctor Sahab, how will you manage the case? Sir, I will do surgery for the patient. And some people are smart enough, they will directly say, sir, I will do canal wall down for the patient. So, Doctor Sahab, here you have to hold. Why you have to hold? Somebody else is joining. Okay? Yeah, so, Doctor Sahab, why you have to hold? You have to give that time to examiner to ask you questions. Because if you will directly jump onto surgery, so आपने बीच के around you have skipped 5-6 steps. Okay, so the answer which is my advice should be, sir, I would like to evaluate the patient further. I would like to evaluate him further. So he will ask you, or if he doesn't ask you, sir, how will you evaluate? The first thing you will do is PTA, because PTA is not included in your history / examination / diagnosis. वहाँ पे PTA का कोई नाम नहीं है. So as soon as you are giving your viva, the first thing you should start, sir, I will do the PTA. Then the thing is, why will you do your PTA for the patient? So sir, I would like to know the degree and the type of hearing loss. Apart from this, anything else? Yes, sir. Sir, I would also like to document my hearing loss because it is a medico-legal thing. It's a medical legal thing. Okay, so you got your 1 marks over here. Suppose the examiner had kept 5 marks for your reaching till diagnosis. If you directly say, sir, CM squamous के लिए मैं canal wall down करूंगा, so you will get only 1 marks. But if you go step by step, तो PTA का 1 marks उसको पता चल गया कि हाँ, this guy knows about PTM. I was even asked to plot a PTM. Okay, so people who are in first year or still in hospital setup, kindly go through that machine. अपने audiologist से बात करके try plotting a PTA also. Okay, चलो. After doing a PTA, what will you do, sir? Sir, I would like to do automicroscopy for the patient. अच्छा, why do you want to do automicroscopy? For automicroscopy, 2 things are there, which is important. First is to confirm the diagnosis. For suction clearance, or to see any site of granulation tissue, to see the status of your ossicles, to confirm the site, exact site of origin, and posterior limit of cholesteatoma. The things which you are not able to visualize in a routine setup of your otoscope or the endoscope, what you have to do, then you have to follow it with the automicroscopy session. So your first thing will be PTA, second thing will be automicroscopy, and third thing is if you want to take any sample from anywhere. Okay, after automicroscopy, now this is a dilemma question. Okay, whether to answer X-ray mastoid or whether to answer HRCT temporal bone. See, examiner will be like he can have your happiness if you say X-ray mastoid also, then also, and even if you don't say also, then also he can have your happiness. Example, like then he will ask you after automicroscopy, doctor, what will you do before the before taking up before the final management? Sir, I would like to do X-ray mastoid. Okay, so if he's a kind-hearted fellow, he'll tell, okay, chalo, move forward. What will you look in X-ray mastoid? So you will answer that same stat points. Sir, I would like to look for pneumatization or sclerosed mastoid. Sir, I would like to look for the any like levels of my sigmoid and all. अब यहाँ पे क्या है? Examiner यहाँ पे आपको he can fix you also. कि अच्छा in today's era you will not like to do a CT scan. So believe me, on the day of the examiner, day of the examination, whatever the examiner says, he is right. Don't argue with the examiner. No, sir, this is right. This is written in that book. Yes, sir. Whatever he says, yes, sir. ठीक है, उससे लड़ाई नहीं करना है. You don't have to argue and fight with the examiner. You have to say yes, sir, and move forward. Okay. So suppose you say HRCT temporal bone first. So this is what I told. Sir, I would like to do HRCT temporal bone. Acha, you would like to do HRCT temporal bone. India is such a poor country, and you won't like to do an X-ray. But so yes, sir. Sorry, sir. I would like to do an X-ray mastoid first. Got my point. So you have to, basically the thing is you have to defend yourself whatever you are saying. Okay? No arguing with the examiner. So why would you like to do HRCT temporal bone, sir? I would like to do HRCT temporal bone because I am a new surgeon. So I want to know the anatomical landmarks and any abnormalities in the anatomy. So what can be the abnormality? What is the level of dura that you can see? Sigmoid sinus kidhar hai? That you can see. Third, status of your hypotympanum. Like any glomus or any high riding jugular bulb, that can be seen. And apart from fourth thing will be your facial nerve, whether the nerve is dehiscent or not. Apart from that, ossicles, okay, or any fistula. Okay, this is like a sort of dilemma based questions, because senior surgeons, they generally don't do HRCT temporal bone, or some people in the newer setting, they do HRCT temporal bone. But one answer which you can give for anything is your, sir, in my institution we do this. Sir, this is my institutional protocol. जहाँ पे कुछ नहीं समझ में आएगा, answer this thing, institutional protocol. ठीक है? This is a way to escape the things. ठीक है? And you should be familiar about the things which are going in your institute. That's a like very genuine thing. So if you get stuck somewhere, this is the word you have to utter. Okay? So after doing HRCT temporal bone, I would list the patient for surgery. Okay? So for surgery. So for surgery, what will be your aim for the surgery? So for your aim for your surgery will be, first will be total eradication of the disease. This should be your first aim. Total eradication of disease. Then restore the hearing. And third will be then the normal anatomical appearance. ठीक है, this will be the aim. Now he will ask you what type of surgery will you perform for the patient. Okay, what type of surgery will you perform for the patient? So now here again the ball is in your court. You can decide how you want to answer this question. See, what will be my advice, like how we were taught in our college is, sir, as per our experience, we are freshers, I would like to do a canal wall down for the patient. ठीक है, here examiner can again fix you कि if the cholesteatoma is very limited, and why do you want to do canal wall down itself? Because as far as the today's era goes, the experienced surgeons, they generally avoid canal wall down due to the multiple subsequent problems which happen in the canal wall down. Okay, so people nowadays are doing limited canal wall down with reconstruction. They will reconstruct the wall in the same sitting itself, which generally is not possible with the experience which we have as of now. Okay, so you can say, sir, in my capacity, I would prefer a canal wall down procedure. Okay, so from here, as soon as you utter your word, this is the, again coming to your important thing. This you cannot forget. Canal wall down, canal wall up. ठीक है, the paper which I have shared with you, those 100 questions with your viva, in those you classically it is described separately. What are the advantages of your canal wall down? What are the disadvantages of canal wall down? ठीक है, canal wall up में what are the advantages of canal wall up? What are the disadvantages of canal wall up? ठीक है, all these answers I will update from that PDF and send it as a composite one. Okay, so don't worry. So this you have to rectify type of things. There are certain things which you cannot afford to miss. This is one of them. ठीक है, you cannot afford to miss differences, oblique advantage and disadvantage of your canal wall down versus canal wall up procedure. Okay, now coming to another thing. So doctor, why will you say it's a squamous disease? ठीक है, so how to approach this is a very common question, very common viva based question. How will you say कि sir this is a squamous? Sir, I would like to say it is squamous because sir, the history. You can start from the history. You can state the examination findings of squamous. So in history, what are the features in history which will tell you that this is a squamous disease? First thing, it's a foul-smelling discharge. It is a blood-stained discharge, plus minus. Third, the discharge is scanty. And fourth, the discharge is continuous. ठीक है? So guys, the people who are in first year, you have to go through each and every word for this thing. ठीक है? COM and facial nerve कुछ नहीं छोड़ना है. ठीक है? You don't have to miss any word, because as soon as you will utter कि sir the discharge the patient which is having is a scanty discharge, so it will be followed by the question why are you saying why the discharge in COM squamous will be scanty. As soon as you will say sir this is a foul smelling discharge, second question will be following it. He is waiting with that question. Sir, why the discharge will be foul smelling in your squamous? Why will it be blood stain and why it will be continuous? This service you will compare it with COM mucosal part. So Dr. Sahab, how will be the discharge in mucosal? Will it be continuous or intermittent? Anybody awake?
Intermittent.
Mucosal में कैसा होगा?
Intermittent.
Will it be profuse or will it be scanty?
Profuse.
है ना? So why will it be profuse? Because the main pathology in CO mucosal is the middle ear mucosa, है ना? Middle ear mucosa, which consists of your goblet cells. So as soon as these goblet cells are inflamed, they start to secrete out the discharge, and the patient will give you the classical history कि sir the discharge is so copious that when I sleep it even comes down and it stains my pillow, it stains my clothes. इतना profuse होगा, but the history which will be given in your squamous will be sir there is certain discharge, I can feel it is wet, but generally it doesn't comes out from my ear. Okay, Why is it continuous and foul smelling? Because see, in the squamous, the main pathology is that it is a continuous, relentless process of putrefaction, है ना? So the bones which are there, the bony things which are there, they start getting putrefacted. Ossification उसका खराब हो रहा है. So because when the bone start getting necrosed or decay, so उसमें इतना ज़्यादा discharge नहीं हो पाएगा. It cannot be so much that the discharge comes out from your ear. So it has to be scanty. And because of the osteitis which is taking place, this is the word which you have to occur, okay? Osteitis, the putrefaction. Because of that, that foul smell is there, okay? So this is the difference which you have to utter. I'll write it in a PDF format. Hai na? Please don't forget those 20 questions which are there for the Viva. Please, please, please. You have to ratify everything out that. 20 pages mein 100 questions are there. So, now, and in the scheme of examination, like in examination, can you have any finding which will suggest you ki whether the disease is squamous or mucosal? Yes, sir. In mucosal, generally we have the perforation which we have. The perforation is central. You are able to see the margins around it. There is no retraction and all. But coming to coming to the squamous part. In the squamous part, there is retraction either in the pars tensa or in the pars flaccida. Now, जब ये बात हुई है, again rectify part 2. Rectify 2. Pars tensa retraction is given by which classification, Dr. Saab?
Shades classification.
And pars flaccida?
Not classification.
टॉस. ठीक है. अच्छा, इसको I'll just like to do a little bit of improvisation. It's साडे. ठीक है. ठीक है. Just look it again in Google. ठीक है. States या वो भी बोल सकते हैं. तो साडे and बर्को. ठीक है. This is the name which is given. Second is your toss. ठीक है. This along with its अंदर का grading, you cannot forget. ठीक है. नहीं भूलना है. You have to remember it. इसको लिख करके write it down on a piece of paper and stick it in front of your wherever you study. ठीक है. Because it is very confusing. Believe me, I have seen people fumbling on it. It's very silly mistake. Anybody can forget it at the time of exam. But when you have your time with you, when you know that still we have 1 month for the results to come, followed by that again 1 month will be there for the exam to be held. Please, all these things should be like done away with. Apart from this, 2-3 things I am writing. Please remember it. Facial recess, sinus tympani, and Prusac space. ये सब मैं इसमें PDF में इंक्लूड करके भेजा हूँ. Just have a look at it. ठीक है. Have a look at it. ठीक है. You cannot afford to forget these 5 things. ठीक है. Coming ahead. Okay. इसके बाद scheme of examination you have done. Now, in scheme of examination, I would like to lay stress on 2-3 point of things. I think मैंने आगे लिया हुआ है. अच्छा. Guys, don't be surprised that like this is what I saw during the whole 3 years of residency. We used to get welcome, Dr. Saab. ठीक है. Like during the whole 3 years of residency, we used to get all elderly and male patients. But during the examination, I got a child. ठीक है. So the initial 10 minutes I was not able to console myself only that how will I go about this case. Like I have never examined such a patient. Okay. So in like what this is my advice to you guys is nothing is different. Only the theory part will be different. Theory जो questions है, they will be different for the pediatric cholesteatoma. Okay. So 2-3 things which you have to remember for your pediatric part. These are that you should be remembering the definition of pediatric cholesteatoma. There are 2 classifications which are there. ठीक है. Learn it for your OSCE part also. है ना? They can very well ask you what is the Derlaki and Clemens criteria for pediatric thing. They can very well ask you Derlaki and Clemens criteria. Second will be your Levinson criteria. ठीक है. Levinson के नाम से we have 2-3 things in your entire ENT. So Levinson's again becomes an important part. Okay. So this is I've included it over here. ठीक है. Definition is here. Okay, whatever you want to see, this is from Scott Brown itself, and this is the Derlachian Clemens criteria, and this is the Levenson's criteria. है ना? Please go through it. You have to slowly build it. Believe me, this will not happen in a day. Don't get dejected by the fact that I'm not able to remember this overnight. No, it is not humanly not possible. Okay. Now, apart from this, etiology, है ना? The examiners are generally old people. है ना? They like to grill you on those silly theory questions, which they might have learnt during their examination time. Okay, so coming to this thing, etiology, you can remember it by this mnemonic: time, parts. ठीक है? तो इस mnemonic के हिसाब से T goes for your teats. Okay, then M is for your Michael theory. Friedberg, Dietz, Michael, then Friedberg, Amy, Reuts, Toss, and Sardin. Okay. So for a ready reference, I have mentioned 2 points over here, but at least remember your name. Names you should not forget. है ना? There will be times if the examiner gets stuck, please tell me what are the theories of pediatric cholesteatoma. So you have to remember it. है ना? You have to answer, then only he will move ahead. And all. Welcome, Dr. Saab. ठीक है? So after moving through this thing, staging the same thing. 3 stagings are there. Derlachian Clemens staging, this is essentially saw. Second is your Portsick staging, and third is your Nelson staging. Okay, so please remember this. This can be a potential question for your OSCE itself as well. They can give you a picture of an ear. I'll share such pictures in a day or two. I'll reach and send it to you. Usme they can give you a GIF based question or a simple image of a question in which cholesteatoma is there. It will be clearly visible that there is some retraction or there is a cholesteatoma, and they can, in the theory part, they can ask, this is a 10-year-old boy who has already been operated, and this is the picture which you see. What are the staging for this which you can plan? So they can either ask you to name the staging, and they can very well ask you to expand it. So these 3 things, your Derlachian, Clemens, Portsick, and Nelson, please don't forget. Okay. So pediatric के बाद यहाँ पे अगला जो क्वेश्चन आता है, last question will be adult versus pediatric cholesteatoma. Okay. So in adult versus pediatric cholesteatoma, you have to remember that pediatric cholesteatoma is aggressive in nature. It is aggressive in nature. It has more tendency to recur, and therefore people advise either the surgeon should be so competent that he removes everything. Otherwise, people generally do a canal wall down for these patients. Okay. Now coming to this our old friend, this adult cholesteatoma. In adult cholesteatoma, I'm starting it from the reverse. Okay? Normally we study definition of cholesteatoma, types of cholesteatoma, theories of cholesteatoma, followed by everything. So I'm starting it from the reverse. Okay? Reverse matlab the recent advances in your cholesteatoma surgeries. 3 names you have to remember. The first one will be your Stamco classification.
Sir, here I want to ask something. Sir, in that pediatric cholesteatoma, actually, there was a question in the exam. What are the primary and secondary principles for the management of secondary pediatric cholesteatoma?
See, जो उसका PDF है, accordingly that I will share it with you. Normally what happens in all the answers which you are answering in Viva, basically you have to support whatever you are saying. So the one thing which goes is either the surgeon should be so competent that he removes every bit of cholesteatoma. Okay, but generally what happens is sometimes it's humanly not possible. Sometimes there are certain errors because of which residual cholesteatoma remains behind, which in due course of time forms a cholestodoma and occurs in your residual disease or recurrence of the disease. So in such type of cases, people have promulgated use of canal wall down. So in case of canal wall down, you have more exposure. So more exposure means more chances of complete removal of disease. That is one thing that you can answer. Baki iska what all things you can write in your exam, I'll get back to you. है ना?
Okay, sir.
Primaries and secondary. I'll write it over here. I'll just have a look. Primary and this is you wanted to say, na? Primary and secondary management of pediatric cholestodoma.
Yeah, sir.
Okay, I'll look at like what else recent literature is available. Okay, so if something is extra available apart from these things, I'll definitely upload it on the group.
Okay, sir.
Okay, so now coming to this Stamco classification. See, in case you are preparing for theory, these guys, first year guys, जो अभी first year, second year वाले हैं, उनके लिए important है, ठीक है? कि this Stamco, one thing is they can easily ask what if the areas which you look in your Stamco classification, so you should be remembering it over here. What is the sites where the cholestodoma is there? The first one is your difficult anterior area. Can you see this thing where they have? I'll like to color it. Okay. The first thing is your anterior area, like the area involving your thorax space and all. That is your first part. Second is H2 is your over here. Okay, somewhere near the station tube orifice, below the around the round window area, that is your difficult posterior area. And apart from this, T will be your tympanic cavity. This is basically the involvement, the area of what is this S? This S is basically the involvement of the areas of your middle ear with cholestodoma. That is your STAM. C stands for your complication, whether any complications are there or not, C1/C2, and O stands for your ossicular status. So this is how you divide the classification according to the involvement of cholestodoma. This will be asked. Let me tell you, if you are normally answering very good in your viva, so when you will complete your C1 squamous ka surgery, when you will complete, then he might ask you what are the any system which classifies the involvement of areas by cholestodoma, then you have to utter this Stamco classification. Okay, and this you can also use as your pitching in question. Whenever you are answering your viva questions, if the Stamco classification mein, if the cholestodoma is involving the anterior and posterior area, so canal wall down will be a good option. So as soon as you utter this word Stamco classification, he'll ask you what is Stamco classification. So जब ये आता हो तभी उसके बारे में बोलना है. It shouldn't happen that you don't remember the details of this thing and you utter it. So then it will be a problematic thing. अच्छा, second thing is your ENO-JOS classification. ठीक है, ENO-JOS is nothing. ENO-JOS में basically what they can do ask with you is they can even ask you the full form of ENO-JOS classification. जैसे EPOS का full form important है, वैसे ENO-JOS का भी important है. So what is this thing? This is basically European Academy of Otology and Neurotology. And in the same time, the Japanese, they did the same study by the name of Japanese Otological Society. So, इसको combine करके they gave this name as ENO-JOS. ठीक है, the full form, please remember it. Okay, coming to this thing, Samio-Atto. Samio-Atto is basically a operative classification. Baki all these things, Cole classification, ENO-JOS and Stamco, these are basically paper-wise publication. Big people do publications and do the thing. Samio-Atto is a operative classification. Like whenever you do surgeries, anybody of you, they are using in your institution?
Sir, it's like staging and...
Yeah. Samio-Atto mein S stands for staging of the surgery, A is for approach, M is for mastoid canal, whether if the wall is up and down, E is for external canal recon, O is for obliteration. ठीक है। एटो में हो गया, ए इज योर एक्सेस टू मिडिल ईयर, मतलब कौन सा रूट लिया है आपने। टी इज फॉर योर टिम्पैनिक मेम्ब्रेन स्टेटस एंड ओ इज फॉर ऑसिकुलर रिकॉन्स्ट्रक्शन। सी नोबडी आस्क्स लाइक इसके अंदर भी दे हैव सब पार्ट्स, लाइक सपोज स्टेजिंग ऑफ द सर्जरी, तो उसको बांट रखा है 1 2 3 4 करके, दे हैव डिवाइडेड इट फर्दर। So nobody thinks कि you should remember everything, है ना। You should be knowing the heading of Samio, and apart from that there is a website or there is a small app of Samio whenever you do surgeries. Like this I'll like if you are using in your institution, well and good, otherwise this is my like advice to you guys. Whenever you write your notes, जो भी exam going नहीं है, second year third year की बात कर रहा हूँ, the people who are in second year, in third year or in first year also, when you are writing your notes for the tympanoplasty surgery or the mastoid surgery, please open this app. I've shared the link in the group. उसको open करना है and उसमें you can fill it. So if you will start using the app, you will get familiar with this classification. One thing. Second thing is, if there is that protocol of that academics in your institute, you will be looked as something good, है ना। Everybody writes down those notes normally. वही टिम्पैनोप्लास्टी में कि टेम्पोरल स्पेशिया ग्राफ्ट हार्वेस्टेड एंड मेटोटमी डन अंडर ले टेक्निक्स, द सेम थिंग वी स्टैंडर्ड वी राइट इट. If after this we write what is the classification Samio, it will speak highly good about your knowledge. Okay, so guys who are in your first year, second year and third year, please give 5 minutes extra after writing down your notes and use this app to write what is the Samio classification. Okay, Samio के बाद अगला, coming to the traditional questions which are being asked in your cholesteatoma. These traditional questions, what define what if cholesteatoma. So this is the classical definition which goes, first is given by your Abramson, second is by Scott Brown, third is by Shambog. जो भी याद करना है एक याद कर लो, ठीक है। It's not like you have to learn all three. Whatever you want to remember, you can remember. See, this is your Scott Brown वाला याद करना है, वो याद कर लो, and you should be ready कि sir I have learnt it from Scott Brown. It shouldn't happen that you speak something wrong and still you are quoting Scott Brown, है ना, because the examiner knows everything. He will be knowing each and every word of Scott Brown, है ना. So we cannot fool the examiner. You have to tell him, sir I have read it from so and so source. Okay, so these three definitions are there. Whatever is your intellectual ability, उसके हिसाब से याद करना है. There will be people who will be learning all three. There might be people who will be learning 2-3 more. But the thing is, you should be able to reproduce it on the day of Viva. You shouldn't forget it. Right? But you learn one, but please answer the same accordingly. Second thing is what are the theories? Like in the pediatric cholesteatoma, mnemonic which was there, that is time parts. In the theories of your adult cholesteatoma, it goes as TB में CI, मतलब किसी TB के पेशेंट में you are doing a cochlear implant. This is just a mnemonic, ठीक है. So TB stands for your tumarkin, B stands for your basal cell, and CI stands for your Cawthorne and invagination theory. If you have made out any other good mnemonic, so please share it for everybody's usefulness also. अगर कोई mnemonic रहता है, ठीक है. So these are the details. Examiner, if somebody is old timer, he will definitely gonna ask you what are the theories for this thing. So this is the invagination theory, Cawthorne theory, Tumarkin theory, invasion theory. But this is the thing which you cannot forget, because ये जो theory है ये 2015 की है. This is the latest theory by the name of mucosal traction theory. This was given by Jackler. This is a potential OSCE question. There is nothing new in this theory. The same thing which you have been reading in your invagination theory, Wittmac's theory, the same thing. Little bit like words are put here and there, but there is not much of a difference. But the name which is given as is the mucosal traction theory given by Jackler in 2015. This is one of those recent type of question which can be asked. So please don't forget, people who are preparing for theory examination, this is a potential short answer question as well. What is the mucosal traction theory? Whenever you write in your examination, please adopt the way of using flow charts. Arrow बना के लिखना है, rather than writing two big paragraphs. Nobody is going to read them. Please write in flow chart format. Please put this in your habit. If you put it in your habit, definitely it will be there on the day of examination also. चलो अब इसके बाद आते हैं, there are certain very important questions which are there, routine questions which have been asked. Why? What is there in the cholesteatoma which causes this damage? 2-3 names which you have to remember, sir. This is metalloproteinases 2 and 9, TNF alpha, interleukins, rank ligand is important, Ki67, and caspase activation. These are few names which you have to remember if the examiner specifically asks you, Dr. Sir, what are the things because of which there is damage in this cholesteatoma. Then second very important question is, what is the DD of a chronic discharging ear? DD of a chronic discharging ear. It can be a chronic otitis media, it can be TB, it can be malignant otitis externa. रट्टाफाई रीड करो. जहां भी malignant otitis externa दिखता है, please read whatever is given about it. 2 lines above and 2 lines below. Chapter of Scott Brown in your skull base osteomyelitis. That is very important. One. And second thing, यहाँ पे ही I would like to add it, not in this chronic discharging. Wherever in any question which you are attempting, whether OSCE, Scott Brown से पढ़ रहे हो आप या कहीं से भी पढ़ रहे हो, wherever skull base you come across, or base of skull, please read that topic more diligently. ठीक है? As of now, ENT is just not restricted now to ear, nose and throat. It has like expanded to vast arenas. Skull base is one of them. So it remains a very potential topic जहाँ से क्वेश्चन पूछे जा सकते हैं. Apart from malignant otitis externa, it can be squamous cell CA of your middle ear. Apart from that, there can be any foreign body which is retained. These are generally the causes of a chronic discharging ear. Okay, so what are the DDs of cavity in a mastoid? Again, cavities of mastoid, one very important is your cholesteatoma. Then there can be again TB. TB is seen everywhere. So in our setup, TB larynx, very important question. TB otitis media, very important question. One finding which you can get in an OSCE is your tympanic membrane which has multiple perforations. Apart from that, pale granulation tissue can be there. Okay? And examination findings which are not correlating with the history, this is a classical sign of TB. Okay? Apart from this, there can be granulation tissue. It can be an operated cavity. It can be any tumor, or it can be any secondaries which are coming from somewhere. Okay? These are like few of those selected questions. Okay? Apart from this, I would like to mention one thing which I came across in the questions today is this thing, tuning fork. I'll take 5 more minutes to go through these examination. See, tuning fork, though how much basic they remain, but they are a potential part of your question. So as soon as you are gonna answer your sir, tuning fork test में, Rennie's में, this is the finding of my Rennie's test. Sir, this is the finding of my Weber's test, or this is the finding of my ABC test. This is the generally 3 tests which we perform. So, abhi, who will tell me कि Rennie's और Weber में more sensitive कौन सा वाला रहता है? Which is the more sensitive test? Yeah, you should be more confident about it. ठीक है? देखो, Rennie's हम लोग देखो how to remember it. ठीक है? Answer तो ठीक है. Answer can be, we can give right answer over here, and during the pressure of exam we can forget also. So Rennie's generally we do with all these 3. जबकि वेबर तो हम ऐसा नहीं करते ना. वेबर तो जनरली वी डू इट विद 1, जनरली 5 and 2 ओनली. सो अगर 2, 5, 6 पॉजिटिव है, तो व्हाट इज द एक्सपेक्टेड हियरिंग लॉस?
15 to 20 decibels.
अगर 5 and 2 इज पॉजिटिव, देन अप्रॉक्सिमेट एस्टिमेटेड लॉस. अरे बढ़ो आगे, 15 से 20 हो गया, उसको और बढ़ा दो.
20 से 30.
ठीक है. एंड if it is 1024 is positive, then 40 decibels. Okay. So we are ranging from 15 to 30 decibel, 15 to 20 decibel से more than 45 decibel तक we are ranging. So for Rennie's test to become positive, what is the minimum amount of hearing loss? 15. But for a Weber to lateralize, the minimum hearing loss is 5 to 7 decibel. Somewhere they say 5, somewhere they say 7. So you can remember any one of them. ठीक है? So will you be able to answer this question, which is more sensitive? चलो, moving ahead. ABC आपको पता है. Third thing which I would like to mention over here is your malingering. Do you know what is malingering?
Yes, sir. ऐसा दिखाना कि hearing loss नहीं है, जैसे स्टेंजर और चिमानी मूस टेस्ट वगैरह का.
हाँ, ऐसा दिखाना कि hearing loss है, ठीक है? You told just the opposite thing, है ना? That the person who is not having any hearing loss and he is saying कि भैया I have got hearing loss, ठीक है? To gain some favors from somebody. Okay, so for this Shimani means you can remember, but one thing which I would like to suggest is Stengers. ठीक है? Stengers is very important. It is based on something called as Stengers phenomena. This I'll share it with you. How to answer this question? What is Stengers phenomena and how do you perform this test?
When two sounds, similar sounds of higher frequency.
Yes. एक मिनट यार. इसमें आज टुडे any first year is there? आप लोगों में से कोई है जो who is in the first year? ठीक है, चलो. See, this is a very potential question for your FAT examination. ठीक है? कि what are the tuning fork tests? या what are the tests for malingering and what is Stenger's principle? है ना? So please remember this thing. ये हो गया. And इसके बाद जो 2 more questions for the day. When you will answer your otoneurological examination. यहाँ पे जो अगला रट्टाफाई वाला चीज आपको याद करना है, you have to remember this thing is your fistula test. ठीक है? So whenever you start your examination of the ear, कि sir I am examining the ear, pre-auricular, post-auricular, EAC findings are so and so, normal या जो भी आपको डालना है उसमें. Tympanic membrane, affected side you have to answer first. So you tell what is there in the affected side. We will discuss this also, okay? That what to say in these findings. We'll discuss them. Okay. After this thing, second will be your tuning fork test, Rennie's, Weber's and ABC. After that, it does not finish. You have to answer about the otoneurological examination and you have to answer about facial nerve. Okay? So this you have to answer. So whenever you are answering for any test and all, so like examiner asks you, Doctor sir, what is the fistula test? And if you start your answer with this thing, sir, when we alternatively push the tragus in and out, if there is fistula in the semicircular canal, the patient starts to have giddiness. He will give you marks, but what will be a more ideal way to approach such a question? Sir, fistula test is based on this principle. First, how to do it? Sir, we can either do it by applying pressure on the tragus by finger itself, or we can do it by applying pressure through a Siegel's speculum. Okay. And third thing, what will be the interpretation of a fistula test? So this is a more organized way, I'll say, to answer this thing. Fistula test again is a potential short answer question for the people who are preparing for their theory. So you have to do it otherwise. 3 हो गया. चौथा, इसके साथ में जो आपको चीज लगेगी, that is your Siegel's speculum. ठीक है? Siegel's speculum has multiple uses with us, so that we have to remember, है ना? So Siegel's speculum के uses, can I have few of them from anybody?
For magnification of the tympanic membrane.
Yes, and as soon as you will say magnification of tympanic membrane, the second question will be, what is the power of the lens of this thing?
2 times.
2 times. I'll have to check this thing. Shayad something else is there. So we'll check. You also check, okay? Power of magnification. Whether it's 2 times, we'll have to check it. ठीक है. Apart from that, somebody else? One more thing that you have showed, that's the power of, you will magnify the things.
Mobility.
Huh?
Differentiate between retraction pocket and perforation.
Great. Yes, one thing. Third thing, Dr. Saab said mobility. Okay. Anything else which you remember? I remember one more. That is your drug delivery. Okay. If you want to push some drugs into your middle ear, you can use this thing. Okay. This I'll just check. You also check from your end what is the correct. Then we'll come back to you. Okay. Now, last one more thing is left for today. After completion of this thing, you have to answer about nose. Sir, I would see यहाँ पे there is a catch. See, if you have that your posterior anoscopy mirror or D&E setup with you in the examination hall, which is very unlikely, then you can say confidently. Otherwise, you have to, on completion, you have to say, sir, nose examination within normal limit. So he can ask you, what finding do you expect in nose? So you can say, ki, sir, in cases of bilateral disease, when the patient is having COM both sides, there is a possibility of some central pathology. So wherever this will be the central pathology, that will be in your nasopharynx. There will be some blocked eustachian tube. There might be certain adenoid enlargement. There can be allergic changes which can cause these things to happen. Okay. Now coming to the last thing, that how will you say your diagnosis? Sir, the diagnosis is my patient so and so. Full form, okay? No short form in your examination. Chronic otitis media, left, right, squamous, with whatever hearing loss you can appreciate with your tuning fork test, no PTA, with moderate to severe hearing loss, conductive hearing loss, that is also you have to mention here, whether it is conductive or whether it is mixed. With or without complication. Okay, so this is way you should practice how to say your entire diagnosis. You shouldn't say COM. You have to answer it full. Okay, I have seen people forgetting it. This is like humanly not possible. You are working with COM patients for 3 years and you are not able to answer. I've seen people, when I was in my first year, I saw the people giving this exam. They were faltering in COM full form also. So examiner was provoking them. But yeah, it cannot be peritonitis. Please answer otitis media. But that is what the pressure makes us do. This is not someone's fault. This is the fault of pressure. So you have to basically mold yourself to the pressure going techniques. Okay. So next session which when we'll be going through this again COM, we'll be going through ideal history taking. I'll share the PDF of one patient's history with you only, and we'll go through that, all the questions which will be asked. Second and third will be complication, because in this whole setup we have not discussed any complications. Okay, and complications in COM is very important. Okay, so these three things, and from you what I will expect is, one thing is your those 100 questions of Viva, that ratify kar lo. Second thing will be complications of COM from your Shambog. Okay, if you are using anything else, okay, that's fine enough, but all the complications, right, starting from your extracranial, intracranial, blah blah blah, what all those things are there, वो सब कुछ एक बार में होएगा, and then we'll start from A to Z and finish your COM Squamous once and for all. Okay, now any doubt, any problem from your side?
Sir, wanted to ask one more question. एक्चुअली मेरी फ्रेंड से क्वेश्चन पूछा था कि रेनीज ट्यूनिंग फॉर्क टेस्ट में मैस्टॉइड तक जब आप ट्यूनिंग फॉर्क लेकर जाते हो तो कितने डेसिबल लॉस आता है?
Bhai, see, that's what I wanted to tell you. Na, people have made thesis paper on tuning fork test. Okay, so they will find something or the other to catch you. See, that's what is the experience, na brother. If we are just you are trying to pass, and someone who is taking our exam is 30 years he's having, after finishing of the PG is having 20-30 years old experience. So he'll be having multiple amount of exposure to this. You just what I'll request is you just type this question same and just send it to me on WhatsApp. I'll just check on that what loss is there. So I'll try to find out some answer to this. And we'll discuss it in the next time.
Yes, sir.
Okay. And we'll have approximate 1 month time for the result to come minimum. Okay. And followed by that there will be another 1 month for the exam to go. Okay. So please don't get demotivated. That is a very big thing. You have to take care of yourself. That in this type of weather and all, especially in the northern part of our country, the weather is too bad. I came to central part, to some other place, and here I saw the weather is too good. So I was sleeping for the last 2 days, and I was there in MP. Here it's raining from last 2 days. and in my hometown in UP, it's like burning as hot as hell. So you have to, guys, everybody has to motivate himself for at least studying half an hour to 1 hour daily. That is the biggest thing till the exams results are out. ठीक है? And if you guys are like जिनका theory clear हो चुका है, we have many people of those sort also. Those theory people is clear. We are waiting for your exam. Please, you have to put the best foot forward, and we cannot wait for anything. Okay? So you have whatever amount of time which you can spare for your studies, you have to put it in. But minimum, people who have cleared your theory, please nothing less than 1 hour to 2 hours. But 2 hours is a good amount of time which you can put and learn A to Z of everything. है ना? But the only important thing is consistency. This is a very big problem with the human beings. We cannot be consistent. है ना? Till the exam you have to be that. And the people who are waiting for theory results, please don't fall into this trap ki when my results will be out, after that I will start studying. Please, you will be mistaken and you will be deeply it's a deceptive thing. Okay, then you will be taken aback कि भैया अभी तो 4 हफ्ते बाद पेपर आ गया और अभी मेरे को कुछ नहीं आता. See, it's coming to the, like this COM is there, है ना? You have to read the theory from Scott Brown itself, from Shambog itself, है ना? That will come in handy for your theory also. So don't take these things कि this is important only for my practical. This is important for everything. बिना COM के हमारा ENT नहीं हो सकता, बिना facial nerve के ENT नहीं हो सकता. You have to learn it. People who are in first year, start learning the anatomy of facial nerve, and from where to do it, my take will be, you can see videos of Dr. Nazeeb on YouTube. If your concepts of facial nerve is not clear, please see videos of Dr. Nazeeb from YouTube. If you have any problem, do let me know. मैं उसका वीडियो का लेकर के I'll send it to you guys. अगर concept clear करना है एक बार में तो वो देखना है. जिनको भी, like if you are in third year also, अगर concept नहीं clear है facial nerve का कि lateral semicircular canal के नीचे से जा रहा है कि ऊपर से जा रहा है, it is anterior or posterior, so you have to watch it once. Whether the geniculate ganglion is there, from where all the branches all are there. That is the most basic video. Apart from that, you can build upon it from various other things. ठीक है? Just go through them. And in case of any input from your side, please let me know. Dr. Narang, आप please मुझे वो एक बार WhatsApp कर दीजिएगा. ठीक है? And in case of any these type of questions you come across ना, please keep on sending it to me. ठीक है? You keep on doing your work. Let me do it. We'll try to do it. ठीक है? I am generally free after the hospital timings. ठीक है? And I was little bit off track because I was on leave. I was not in my hospital setup. I'll be reaching my hospital setup from next Monday itself. So we'll do this routine of OSCEs and all a little bit more strategically and more consistently. Okay, chalo, see you guys. In case of any problem, do let me know. All the best. Bye. Good night.